Okay, and that's the right view. Yeah, thanks for having me join you today. I hope I'm not keeping you from dinner, but I'll try to move through. We'll talk about T-cell lymphomas and ways that we're starting to incorporate new therapies into our treatment paradigms. These are my disclosures. So this is just a level set or a starting point for where we think about what we do historically with T-cell lymphomas. These are the progression-free and then overall survivals from a Swedish National Registry. So it really accounts for the spectrum of primarily nodal T-cell lymphomas. And you can see here a couple of things. One, that for most of the T-cell lymphomas, we have a lot of room for improvement with progression-free survival in the 20 to 30% range long-term. This is primarily with CHOP-based therapy. And we do somewhat better for positive ALCL, there's still room for improvement. And then I think the other thing when we look on the right is that historically overall survival and progression-free survival have been tightly linked. And that was because of the lack of sort of available or effective salvage therapies, but that's changing as well. And then this is sort of maybe the best we do with chemotherapy. So this is data from the Nordic study looking at upfront transplant and intensified chemotherapy. So if you maximize chemotherapy, you give CHOP etoposide. This was given every 2 weeks for patients under 60. Consolidate responders with auto transplant. At least in a clinical trial setting, you can potentially push those progression-free survival up to the 40-45% range. If you look over on the right, better for ALK-negative ALCL than it is for PTCL NOS. And then the overall survival curves come up close to 50%. This is probably about the maximum we can do by just intensifying chemotherapy. But our understanding of T-cell lymphoma or the biology has really significantly increased really in the last 10 to 15 years and even more recently. Some of the most sort of fundamental insights is this understanding that there's a large group of T-cell lymphomas called now follicular helper T-cell lymphomas. This is angioimmunoblastic as well as some other subtypes that we think the cell of origin, or what's sometimes called the cell state, is really from a germinal center or follicular helper T-cell. And those are characterized by certain mutations, almost always a background of clonal hematopoiesis with TET2, DNMT3A, and then often some additional private mutations in the T-cell lymphomas themselves, which are sometimes things like IDH2 or RhoA. Understanding that biology as well as seeing some of the aberrant signaling in T-cell lymphoma, RhoA, VAP1 through SYK, or other signaling pathways like PI3 kinase or the JAK-STAT pathway have allowed insight in understanding the biology. And because we are starting to have some treatments that target those pathways, we're starting to see those concepts make their way into investigational and I think soon standard therapy. So I think the one principle that I would go back to that we can build on a chemotherapy regimen, so chemotherapy is not worthless, but it's something we could build upon to do better, is the Echelon-2 study. And I hope this isn't a one-off, that we'll be able to repeat this with other concepts. But as those of you probably know, Echelon-2 was a randomized study adding brentuximab vedotin to CD30 positive T-cell lymphomas, randomized double-blinded for T-cell lymphoma. It's a pretty big study with about 450 patients. And that showed an overall benefit in progression-free survival. If you look at the orange curve for BVCHP versus CHOP, and then that led to a benefit also in overall survival. So really the first study we have that showed improvement in overall survival. While those curves run pretty close together, the median PFS was almost tripled, and the OS similarly increased. I think the other thing I point out here is the CHOP arm did quite well. So this study is overrepresented for anaplastic large cell lymphoma, so there may be some more chemosensitivity there. But the median PFS for CHOP alone was 23 months, which was much longer than predicted. But if you look at those curves at 5 years, at 5 years, over 40% of patients remain progression-free with CHOP. And if you look at the overall survival, the median overall survival with CHOP is not met at 5 years. So that the takeaway from that is BVCHP became a standard of care. I think unequivocally overall survival benefit in anaplastic large cell lymphoma, it's what we do. For the other CD30 expressing T-cell lymphomas, it was a little less clear. I didn't go into the details there, but those are underrepresented, not balanced, and the degree of benefit or any benefit at all was less clear, but they were part of the intent to treat subset. And then there's been some other ways that I just mentioned here of looking at adding BV with further intensified chemotherapy that look like there may even be some further benefit consolidating with transplant or adding etoposide. But in terms of new therapies, are there other ways to take the same concept and also move that into an upfront setting to try to benefit more patients? So some of this comes from some data with HDAC inhibitors. So we had the clinical impression that for HDAC inhibitors, primarily romidepsin or belinostat, that patients with follicular helper T-cell lymphomas did better. So we did a retrospective look at a number of centers of patients. There's about 120, 130 patients with T-cell lymphomas who were treated with HDAC inhibitors. We reclassified them with the new classification system, coding them as TFH or non-TFH. And what you can see here is that your chance of response is almost twice as high if you're TFH, and your chance of complete response is also quite a bit higher for TFH than non-TFH. And then we kind of looked the other way. We looked at all comers who had mutational profiling and looked at whether they had those typical TFH mutations, TET2, DNMT3A, RhoA, things that sort of biologically characterize those tumors. And you can see that responders are greatly enriched for those mutations. So this is most of those mutations or some of those mutations are in methylation. These are deacetylase inhibitors. So it's maybe not causative, but there's a correlation between this biology and response to at least HDAC epigenetic therapy. And that idea was taken forward really concurrently, or before the knowledge of particular responses to HDAC was known. And the French, the LISA did, teams keep popping up. The French, the LISA group did a prospective randomized study adding romidepsin to CHOP really in all comers with peripheral T-cell lymphoma. And that data was negative. So disappointing outcomes. If you look at romidepsin CHOP, there was really no difference in complete response or overall response between RO-CHOP and CHOP. Part of that may have been due to the increased hematologic toxicity caused by romidepsin. So romidepsin here was added at 12 milligrams per square meter, which is close to full dose. And it led to significant increases in dose reduction, dose interruptions. And if you look down here at the bottom, the ability to give the chemotherapy on time at full dose, which we think is important, was compromised by the addition of romidepsin. Maybe that was part of the reason, but when the progression-free and overall survival curves were looked at, which were the primary endpoints, there was really no benefit. So the RO-CHOP curve is seen here in sort of blue-green, and it sits above the CHOP curve, but really no significant difference in median or long-term PFS, and then really no difference in overall survival. When they looked at the forest plots, it was almost significant for the follicular helper or the angioimmunoblastic T-cell lymphoma subtype. That was not a planned analysis. So retrospectively, they went back and reclassified the patients as TFH or non-TFH and reran the curves. And when you look at the TFH patients only here, which were 200 patients, this was about half of the study, we get almost doubling of the median progression-free survival with romidepsin versus CHOP. And if you look at the non-TFH patients where romidepsin may have added to hematologic toxicity and reduced dose intensity and maybe didn't benefit those patients so much, you see no difference in really an inversion of those curves. So it may be, had this been done in a different way or powered in a different way, that adding HDAC to CHOP in this setting could result in a benefit for patients with follicular helper T-cell lymphoma with differences, potentially similar in degree to BV-CHP. There's also other therapies that are in development that look promising and maybe less toxic for T-cell lymphomas, including hypomethylating agents, EZH inhibitors, and then some other signaling targets, which I'll talk about briefly. So azacitidine T-cell lymphoma has an interesting history. There was an initial series from France where patients got azacitidine off study. It was about 20 patients, and there was this surprisingly high response rate in angioimmunoblastic T-cell lymphoma. On these curves down here, some of those patients had complete responses to single agent. Some of those responses were ongoing, and really very little, if any, response to other types of T-cell lymphoma. There was a formal prospective randomized study done comparing oral azacitidine here, CC486, versus an investigator's choice of gemcitabine or romidepsin. And then the responses were sort of much more what we'd seen with other types of T-cell lymphoma, about 33% overall. And this was only for angioimmunoblastic T-cell lymphoma patients. Some of those responses were durable, and it did lead to some improvement in progression-free survival. Testing that concept, Girawan and Cornell, who we collaborated with, started a study of oral azacitidine plus CHOP chemotherapy. The idea here is that azacitidine might add single agent activity to the T-cell lymphomas, and they have some data with Ari Melnick and Leandro Ciuccetti looking at sensitizing tumors to chemotherapy by adding hypomethylating agents. This was a phase 2 study. The responses were quite good. Small study, but overall response rate was 75%, all complete responses at the end of treatment. And if you looked at the follicular helper patients, which were almost all the patients in the study, that response rate gets up to 90%. There probably is an increase in hematologic toxicity when we add azacitidine to CHOP, but usually that can be managed, at least in this study, in the academic clinical trial setting. And when Gia presented the PFS curves and the overall survival curves, and she, I think, can update them later this year at ASH, they look quite good. You know, we're comparing to historical controls, so it's hard to make conclusions, but the PFS was 65%. And again, among the TFH patients, the PFS with relatively short follow was almost 70%. Looking at some mutation analysis, again, are there better ways to select patients for the study or select patients to take out of the study who are less likely to benefit? And we've seen this in some other settings where DNMT3A mutations correlate with adverse or poor response to chemotherapy. So again, small numbers here, but patients with TET2 correlated with favorable PFS, and patients with DNMT3A mutations shown here in the red curve, small numbers, but looks like those patients are more likely to be chemo insensitive and may not benefit from combination chemotherapy approaches the same way. EZH inhibition, which the phase 1/2 studies will be coming out soon in Lancet Oncology, are another promising epigenetic therapy for T-cell lymphomas. So unlike in B-cell lymphomas, where there's often gain of function mutations in EZH, there's almost never that in T-cell lymphoma. It's less than 5%. But EZH is overexpressed in a number of T-cell lymphomas and may have pathogenic roles, particularly in follicular helper angioimmunoblastic T-cell lymphoma or HTV1-associated T-cell lymphoma. We studied this initially a phase 1 and then a phase 2 study of balimetastat, 1/2 inhibitor, oral agent given as a single agent with a primary endpoint of response and then progression-free survival, the relapse refractory T-cell lymphoma. And the data looks quite good. So the overall response rate by CT assessment for angioimmunoblastic T-cell lymphoma was over 50%, but good responses in other subtypes. We think PET-based response is probably more reflective of clinical benefit in T-cell lymphomas. So PET was also looked at, even though that wasn't the primary endpoint. And you can see response rates overall, all comers are over 50%, but particularly high responses and complete responses for angioimmunoblastic T-cell lymphoma, good responses in HTLV1 and other types of T-cell lymphoma. So this is another agent that probably has some better hematologic toxicity, more favorable than something like romidepsin, and might be something that's ripe for combination with chemotherapy. Moving on to signaling targets. So as you probably know, JAK-STAT signaling is super common in T-cell lymphomas. It's characteristic of some subtypes like PLL or LGL or many NK T-cell lymphomas, but we also see overactivation of the pathway across the board in many subtypes, anaplastic large cell lymphoma, for instance. And we did a study where we looked at single-agent ruxolitinib in T-cell lymphomas. We grouped them into 3 groups. Patients with activating mutations of JAK. This is sort of a proof of principle study where we thought those patients were most likely to respond. We had another group with elevated phospho-STAT3, where there was evidence of functional activation of the pathway in absence of an activating mutation. Some of those patients may have fusions. And then group C was neither or unknown, and just treated them with single-agent ruxolitinib. And the data was interesting. The responders were most likely for those in groups 1 or 2 that had activating mutations or elevated phospho-STAT3. Response rates of about 30%, so not super high, but maybe clinically meaningful for some patients. And those responses, if you look on the right, really cross subtypes. So patients like LGL or PLL were more likely to respond, but we really saw responses as much based on the biology as the subtype. If you look at clinical benefit, where patients had stable disease or better beyond 6 months, the degree of clinical benefit may be higher than just the response rate. Other JAK inhibitors are in development, and gelidosidenib is a primarily JAK1 inhibitor, another oral agent where a phase 2 study was done, again with high responses, numerically better than what we saw with ruxolitinib, though they're different studies. Overall response rate of over 40%, with about half of those being complete responses. And then again, if you look at subtypes, they saw very high responses in PTCL NOS, less in AITL, lower responses in anaplastic large cell lymphoma, high responses in PTCL NOS and AITL, lower responses in anaplastic large cell lymphoma, which is a little unclear, as at least half of those patients should have JAK-STAT activation, and a small number of patients with NKT cell lymphoma, which are often JAK3 mutated, responded. So it may be that this is another promising pathway to target, and there may be some ways to individualize the treatment or select patients for treatment. We think the ruxolitinib offers a proof of principle that targeting this pathway can be successful. As I showed you, gelidosidenib, there's other JAK inhibitors, there's STAT degraders that more potently hit the target in the clinic and clinical development. And I think kind of sorting out, are there optimal ways to hit this pathway and ways to make combinations are clinical trials that are going on now. The last thing I'll talk about before wrapping up is PI3 kinase inhibition. So this is another pathway that's consistently upregulated in T-cell lymphomas. You're probably familiar with the B-cell story, where these were FDA approved or useful agents, but in long-term use, particularly in CLL, there were some late toxicities, mostly infectious toxicities. So their use and role in B-cell lymphomas has been a little less clear. T-cell lymphomas, where we don't have things like ibrutinib or bispecifics, as you heard earlier, that cause long-term remissions, we think that these drugs really have activity and are still pursuing them. So in the initial phase 1 we did of duvelisib, which is a PI3 kinase delta gamma inhibitor, most of the other PI3 kinases in lymphoma were delta specific. This is just the one that we started working with. In the phase 1, the T-cell lymphoma cohort, we saw about a 50% response rate in PTCL, and about a 30% response rate in CTCL. And again, if you look at this figure here, didn't really sort by subtype. There were sort of responses and non-responses among different subtypes. That led to the PRIMO study, which is a phase 2 prospective study looking at duvelisib as a single agent in T-cell lymphoma. Without going into a lot of detail, the patients with T-cell lymphoma tend to get treated with higher doses, 75 milligrams BID, which is 3 times what was the FDA-approved dose of 25 BID. We did a little dose optimization cohort, and it looked like 75 BID, while more toxic, was also more effective. And that led to a expansion strategy where patients got the higher dose for 2 cycles to try to get early disease control, then were reduced to the lower dose for better long-term safety. There may be some other ways to give these drugs more safely long-term. And this is just some updated data from last year. The study is now complete, and hopefully will be updated at ASH of the phase 2 portion. So these are 97 patients in the expansion cohort. I'll just look here to show you the best overall response. So in PTCL NOS, which was about half of the patients, the response was almost 50%. 2/3 of the patients with AITL responded, so there's some subtype specificity there, and much lower responses in ALCL. And we're starting to understand the biology why ALCL might be less sensitive to PI3 kinase inhibition as a single agent. Toxicities are very important when we're thinking about PI3 kinase, partly because of the experience in B-cell lymphomas. And looking carefully at that, we do see significant levels of transaminase elevation. About 23 or a quarter of those are grade 3 or higher. This is higher at 75, and there may be some other strategies going forward to sort of minimize this. But there is an infectious risk with these compounds. So those strategies are being looked at now in the upfront setting in a cooperative group study going on in the US. So this is a randomized phase 2 study looking at adding oral azacitidine or CC486 to CHOP or CHOEP, duvelisib to CHOP or CHOEP, or a standard arm. And this is an accruing study, and it will look at both the responses and toxicity of these novel upfront approaches, and then also try to do some subtype connection. And are there certain subtypes that seem to benefit more from these approaches? So to wrap up there, for peripheral T-cell lymphoma, it's heterogeneous and it remains relatively poor prognosis. However, I tried to show you that there are a portion of patients that are cured with combination chemotherapy, and there may be ways to build on that for those patients who are chemosensitive. We and others are working hard to identify active agents, and then in addition, trying to understand where those agents work and where they don't, so we're not sort of repeating this one-size-fits-all approach and trying to match therapies with patients as we try to build on chemotherapy. And I think what we're hopefully moving to in the near future are subtype-specific strategies for better results for different subtypes. Some of those will be disease subtypes, but some of those may be molecular subtypes or target-specific subtypes that may cross different diseases. And then I showed you some of the data for some of the newer approaches in combination, epigenetic therapies, signaling targets. I didn't really talk about immune therapy, but that's another topic. So this is a schema we made for a review article recently where we had where we are now and where we may be going in the future. And this is now for CD30 positive T-cell lymphomas, we give brentuximab in combination with chemotherapy and have a bias for auto transplant. For CD30 negative, I think standard treatment is now still chemotherapy or more chemotherapy. But maybe we'll move in the future, and maybe not the too distant future, where we might be thinking more subtype specific. Maybe TFH patients will get an epigenetic modifier or a PI3 kinase inhibitor in combination with chemotherapy, as a single agent activity in TFH is quite good for those. There may be different types of T-cell lymphoma based on the biology, where a PI3 kinase or JAK-STAT inhibitors may be optimally combined with chemotherapy. And then some of these other primarily chemo-refractory or almost universally chemo-resistant lymphomas, you might need wholly different approaches that maybe include some things like immunotherapy or non-chemotherapeutic approaches. So I will end there, and happy to take questions.